May I start, sir? May I start, sir? Thank you, sir. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. لو أنزلنا هذا القرآن على جبل لرأيته خاشعا متصدعا من خشية الله. وتلك الأمثال نضربها للناس لعلهم يتفكرون. والله الذي لا إله إلا هو عالم الغيب والشهادة هو الرحمن الرحيم. هو الله الذي لا إله إلا هو الملك القدوس السلام المؤمن المهيمن العزيز الجبار المتكبر. سبحان الله عما يشركون. هو الله الخالق البارئ المصور له الأسماء الحسنى. يسبح له ما في السماوات والأرض وهو العزيز الحكيم. صدق الله العظيم. بلغ العلا بكماله كشف الدجى بجماله حسنت جميع خصاله صلوا عليه وآله. Lieutenant General Mohsin Mohammad Qureshi, Hilal Imtiaz Military, Surgeon General, Director General Medical Services, Inter-Services, distinguished guests, members of the society, ladies and gentlemen. On behalf of President and Executive Council, Pakistan Society of Nuclear Medicine, I welcome you all in the 8th Annual Conference of Pakistan Society of Nuclear Medicine. The title of conference this year is Nuclear Medicine in Pakistan, Generation Next. As we have already started, I invite Dr. Shazia Fatma, President, Pakistan Society of Nuclear Medicine, Director, Karachi Institute of Radiotherapy, Oncology, and Nuclear Medicine, for a welcome address. Dr. Shazia Fatma.
Thank you very much, Dr. Anam. Good afternoon, ladies and gentlemen. Our worthy chief guest, General Sohail Qureshi, Hilal-e-Imtiaz Military, Director General, Pakistan Atomic Energy Commission and Nuclear Medicine and Oncology Centers, Dr. Ahmed Qureshi, Professor Lee, Dr. Azra, ladies and gentlemen, and esteemed colleagues, distinguished guests, and fellow contributors to the field of nuclear medicine. Today, we gather at a juncture where our past achievements blend seamlessly with the promise of brighter future. I am deeply honored to stand before you as the President of Pakistan Society of Nuclear Medicine to welcome you at 8th Annual Conference. This prestigious gathering is more than just an event. It's a beacon of knowledge, a platform for innovation, and a testament to our shared commitment to the ever-evolving field of nuclear medicine. First and foremost, I would like to express my profound gratitude to our Chief Guest, Lieutenant General Mohsin Mohammad Qureshi, Hilal-e-Imtiaz, Surgeon General DG MSIS, for gracing us with this esteemed presence. The schedule for this conference encapsulates the dynamism of nuclear medicine, from precision medicine for cancer treatment, exploring the cutting edge in theranostics, to understanding the transformative role of hybrid imaging. Our discussion promised to be both enlightening and impactful. Beyond the presentation, our workshops stand as pillars of hands-on learning, designed and led by international and national luminaries. These sessions aim to equip every participant with the practical skills and insights, whether you are delving into the nuances of radiotherapy planning or intricacies of advanced imaging modalities. The vibrancy of our field lies in its youth. And I am thrilled about our exclusive session designed for next generation of nuclear medicine practitioners. These workshops will enable budding professionals to engage, learn, and seek mentorship from stalwarts, thus laying strong foundation for their future careers. With speakers from diverse geographical locations, we are indeed a global community. Our shared goal is not just individual learning, but forging connections, collaborations, and partnerships to elevate our field. Pakistan's journey in nuclear medicine, though laden with challenges, has been one of determination, resilience, and progress. As we convene today, let's remind ourselves of our unwavering commitment to providing better healthcare solutions and brighter prospects for our patients. As we proceed, let me also draw your attention to a unique segment where we incorporated this year's our award ceremony. In our endeavor to recognize exceptional talent, we will honor budding stars with the Young Investigator Awards. Furthermore, our Professional Excellence Award will be a homage to seasoned physicians whose lifelong contribution have paved the way for many. In conclusion, I urge each one of you to fully engage in this conference. The tapestry of knowledge, innovation, and collaboration awaits you, your unique thread. Let's remain anchored to our core mission, enhancing the quality of life through the continued evolution of nuclear medicine. Thank you for embarking on this journey with us. Welcome to the 8th Annual Conference of PSNM. As we dive deep, let's learn, innovate, and together shape a better future for nuclear medicine. Thank you very much.
Thank you very much, ma'am. I now request the chief guest of today's ceremony, Lieutenant General Mohsin Mohammad Qureshi, Hilal-e-Imtiaz Military Surgeon General DGMS IS, to please declare the conference open.
I declare the conference open.
Thank you, sir. We now proceed for the clinical session. The chair for this session is Lieutenant General Mohsin Mohammad Qureshi, Hilal-e-Imtiaz Military Surgeon General DGMS IS. He is joined by co-chair for this session, Dr. Ahmed Qureshi, Director General Nuclear Medicine and Oncology Group, Pakistan Atomic Energy Commission. And I request Dr. Shazia Fatma, President, Pakistan Society of Nuclear Medicine, to moderate this session and introduce and invite our keynote speakers.
In this clinical and academic session, we have two keynote speakers. I welcome our first keynote speaker, Professor Umar Mahmood from USA. He is Chief of Nuclear Medicine and Molecular Imaging, Director of Center of Precision Imaging, and Associate Chair for Imaging Sciences in the Department of Radiology at Massachusetts General Hospital. He is Professor of Radiology at Harvard Medical School. In addition, he serves on the board of directors of RSNA. Dr. Mahmood is a fellow of US Society of Nuclear Medicine and Molecular Imaging, SNMMI, and the recipient of first annual SNMMI Minoshima Papa's Transformational Leadership Award. He has also served as SNMMI Board of Directors and as a chair of SNMMI Scientific Program Committee. He was unable to join us, so his lecture will be shared online, and then he will be available with us for question-answer session. Dr. Umar Mahmood, thank you very much.
Hello, my name is Umar Mahmood. I'm Chief of Nuclear Medicine and Molecular Imaging at Massachusetts General Hospital in Boston, Massachusetts. It's a great honor and pleasure to be able to speak at the Pakistan Society of Nuclear Medicine. I only regret that I can't be there in person, and I truly hope to be in person in a future year. Today I'm going to be talking about precision imaging to guide cancer treatment. And what that really means is helping determine the right therapy and the right dose for each individual cancer patient. In terms of disclosures, in addition to my job at Massachusetts General Hospital, I'm a co-founder of Cytocyte Biopharma, which focuses on immuno-oncology imaging. Since this is a nuclear medicine meeting, I thought I'd start by showing a picture that we see every day, which is fluorodeoxyglucose metabolic imaging for both detection and for response assessment. So on the patient on the left, a patient with ovarian cancer post-surgery with rising CA-125, the anatomic imaging, while having high spatial resolution, provides poor contrast between the tumor focus, shown in red, and the adjacent bowel loops. It's based on its difference in metabolic profile compared to the normal tissue metabolism that we can readily see the tumor focus. And on the right, we can see in a patient who has lymphoma that the FDG imaging provides an early assessment of treatment response. And that early imaging with early insight into treatment response often occurs before anatomic changes occur. So the question becomes, what is precision medicine? Why do we care? And how do we use nuclear medicine to help us answer questions surrounding precision medicine? And what precision medicine is really focused on is that we're all different. We have slightly different genes, or our environmental exposures are different, and our lifestyles are different. So the basic concept is that while we have many things in common, we also have things that make us individuals. And most medical treatments have been designed for the average patient. As a result of this one-size-fits-all approach, treatments can be very successful for some patients, but not for others. Now, patient heterogeneity has always existed, and many gains in clinical medicine over the last 50 years were achieved by medical insights that were uniformly applied to large patient groups. I believe many future gains will be achieved by fractionating patient populations into smaller and smaller groups. And the question is, why now? What are the drivers of relevancy? Why is precision medicine becoming such a hot topic today? And that's because we have more medically relevant data. We have a greater biological understanding of disease, especially in cancer. We have improved data analysis tools, and we have an increasing number of well-controlled clinical trials that provide outcome data so that we can, when we have additional input, we can use that to help optimize different dosing and different strategies. We also have more therapy choices. There are more novel classes of targeted therapies, and within these classes of therapies, we have more choices to allow pharmacokinetic and other tailoring. Now, the real take-home of precision medicine, and if you don't remember anything else, I think this title slide really is the take-home message, which is we want to improve group outcomes by optimizing each individual outcome. So let's say we have a group of patients with a type of cancer, and we treat them all with the same therapy and same dose. Some patients will do well, shown in green, and other patients may do less well, unfortunately. Now, if we had a way to differentiate, for example, how much of a receptor was overexpressed or how many, which types of receptors are overexpressed, we could tailor that therapy. So in addition to helping patients who have overexpression level or receptor A, we could also help patients now who have different expression levels by optimizing that dosing or giving different therapies. And we've done this for many years. For example, with eyeglasses to correct nearsightedness, we don't give everyone the same eyeglass prescription. We don't give everyone the same blood transfusion, we type match. And with antihypertensive, we give different doses and different types of antihypertensives. And this is also true of targeted cancer therapies. And as we have more and more targeted cancer therapies, we can now use that. We need additional information to help optimize how we couple those targeted therapies to each cancer patient. Now, when we think about the heterogeneity between all of us in cancer populations, there's really two approaches. One is a radiogenomic approach, and I know there's going to be lectures later in this meeting about that. And radiogenomic approaches really often will use anatomic or physiologic images and have a large n-value data sets. Now, they tend to be less specific for individual genetic changes, and that's because phenotype doesn't match one-to-one with genotype. But they can assess the probability of a number of different disease states. For example, on a chest CT scan, we can look for COPD, for lung cancer, for infection. And images can contribute to a large system of weighted probabilities that include electronic medical record data. And we can use that information to make multiple small increments, which sum into meaningful probability assessments. So if we have some features on a chest CT, we might be able to tell the probability or increase the probability that of knowing that there's certain mutations, for example, EGFR mutations or ALK mutations in that lung cancer. Now, molecular imaging approaches tend to be somewhat different. We tend to inject molecular targeted agents. We have a high degree of quantification of a specific target, but we have a limited number of targets that can be assessed. And imaging intensity often correlates with a specific protein or gene expression. Now, molecular imaging approaches tend to be somewhat less good for screening settings or unknown disease states, but we can often use them to characterize already identified cancers to help guide drug selection or dosing. It's really, another word for it can be companion diagnostics. And when we think about molecular imaging, how does molecular imaging help? Well, if you think about cancers, and actually many diseases, molecular processes drive disease. So we improve disease detection with higher contrast and anatomic imaging, as the ovarian cancer case I showed earlier. We can also stratify patients in terms of which targets are overexpressed and how much. And that's because targeted therapies don't work in all patients with a given type of cancer or other disease. So for example, Herceptin won't be helpful in a patient who doesn't overexpress HER2. And we can also determine if dosing of a molecularly specific therapy is adequate. Many new drugs are pathway specific and toxicity may not be dose limiting. And therefore we need a readout for dosing. And we also have an easier evaluation of combination therapy using molecular imaging. And if you're trying to optimize, for example, 3 different drugs in a drug regimen, it's easier to assess individual parameters of each drug separately, and molecular imaging can help us do that. One of the other things in cancer therapy is determining cellular response or resistance, and we can do that by, for example, imaging proliferation or looking at surrogates, for example, looking at changes in metabolism as a marker of response. Now, biopsies give us a lot of information, but repeat biopsies are not that common, except in usually in phase 1 or phase 2 clinical trials. So imaging can potentially replace repeat biopsies and sampling, which aren't often feasible in regular clinical practice. So in this era of precision medicine and molecular imaging, they really dovetail to form precision imaging. Now, cancer is quite complicated, and there are multiple pathways that are involved in regulation of cell growth and making sure that cells communicate with one another. And there's a great series of papers that were published over the last 20 years by Doug Hanahan and Bob Weinberg called The Hallmarks of Cancer. And one of the real, I think, insights that they showed were that there's a number of things that make a cancer cell a cancer cell. So there's sustained proliferative signaling, there's evading growth suppressors, there's avoiding immune destruction, there's a number of other factors. And by using these large frameworks or these large buckets, they help provide some semblance of order on understanding how cancer signaling works. And if you look at the around each of these hallmarks of cancer, there's specific drugs that have been developed to target different abnormalities in types of cancer. What's always been impressive to me is how much relevance our imaging, nuclear medicine imaging and molecular imaging have in these understanding and being able to assess these different pathways, both for looking at abnormalities and looking at response to targeted therapies. So for example, in cell signaling and growth receptors, we can image receptor tyrosine kinases, we can image EGFR, we can image HER2, we can look at hormone receptors, for example, the estrogen receptor or androgen receptor. We commonly image the somatostatin receptor. We can also look at tumor cell energetics. We can image sugars, we can image lipids, we can image nucleic acids, we can image amino acids. We can also look at angiogenesis, looking at integrins, looking at perfusion agents. We can also look at replicative potentials, looking at DNA synthesis agents. And we also have markers of invasion and metastasis. Now, one of the nice things about FDG, which is a common downstream pathway for a lot of, even with targeted therapies, cancer cells often will change their metabolism, is that we can use that as a marker for early response assessment. So even not only for standard chemotherapies, but for also molecularly targeted chemotherapies. So in the upper left, there's BRAF inhibitors given in these patients with melanoma, and you can see very early on that there's changes in glucose metabolism. Likewise, ALK inhibitors in non-small cell lung cancer on the upper right, or P110 alpha inhibitors, part of the PI3 kinase pathway in ovarian cancer. And as all of these therapies are being developed and being used more and more in clinical trials or clinical practice, we can use standard imaging agents like FDG often to look at that downstream response assessment. And in the US, FDG, fluorodeoxyglucose, is used between 2 to 3 million times a year. Now, it's important to remember that tumors are not just cancer cells, but there's a microenvironment. So tumors are made up of tumor cells, of course, but also blood vessels, stroma, immune cells, other types of material that forms a tumor. And as part of treating and understanding cancer, we not only want to be able to image the tumor cells, for example, using things like cell receptors, prostate-specific membrane antigen, somatostatin receptor, others. We can also look at glucose or amino acid as part of looking at the tumor cells. But we have abilities to look at immune cells that that are often involved in the tumor microenvironment, and that involves a number of different tracers that I'll be talking about later, including CD8 or granzyme B, reporter genes or macrophage agents. We can also look at the host response, or the host stroma, looking at fibroblasts. So fibroblasts, when you have a wound, help with healing, but there are cancer-associated fibroblasts that have abnormalities that can potentially make cancer cells grow faster, and there's ways to image that with fibroblast activation protein imaging agents. We can also look at blood vessels directly as well. Now, in the last 5 years, one of the areas that have really caught nuclear medicine by storm is looking at that host response, looking at the fibroblast activation protein inhibitor. And the seminal work, the early work, has been done out of Heidelberg by the Heidelberg group, and you can see in a lot of different cancers that fibroblast activation protein inhibitor is overexpressed on the fibroblasts, which enable us to improve detection of a number of different cancers. And I believe that there's going to be a lot of benefit to understanding which cancers are imaged by best by FAPI, and which are better assessed by glucose metabolism, for example, by FDG. And as we grow our armamentarium of ways to image, we will need to understand when to use which imaging agent best. So as I mentioned, there's a number of different imaging agents we can use. For prostate cancer, one of the things that's really quite remarkably replaced how we've been doing imaging is using PSMA-targeted agents, prostate-specific membrane antigens, for imaging and radiotherapy. And it's basically in a number of prostate cancers, PSMA is overexpressed, and as there's neoplastic transformation, that PSMA is moved to the luminal surface, making it easier for the imaging agent to reach it and be able to then image it. It's significantly overexpressed and further increases in advanced stages of cancer. And we are doing about 10 cases of PSMA imaging a day at our institution, and it continues to grow. And I know we're going to hear a number of great talks on PSMA in this meeting, as well as not only for imaging as well as for therapy. And just some examples, I think what's remarkable to me is it used to be that bone scans were typically performed for prostate cancer, and as time goes on, then it was replaced by fluciclovine, looking at amino acid imaging for prostate cancer. And now in a lot of the world, the gallium or fluorine PSMAs are dominating just because of the very low level of PSA levels that can be used, or where imaging can be effective in detection. And the imaging agents have gotten so good with PSMA that there are whole fields of treatment that are growing because of that. So for example, because of PSMA, the concept of treating oligometastatic disease and prostate cancer is growing, as opposed to jumping straight to systemic therapy when there's a few metastatic foci. Now, in breast cancer, there are a number of abnormalities that can occur. One of the things, if there's estrogen receptor overexpression, is there are drugs that block the estrogen receptor or drugs that degrade the estrogen receptor, selective estrogen receptor degraders, or SERDs. We can use an analog of estrogen to image the estrogen receptor, and we can use this potentially for optimizing dosing. So fluoroestradiol can be used for PET imaging of the estrogen receptor. This is a mouse study where it just shows that with doses of fulvestrant, which causes estrogen receptor degradation, that increasing doses cause the degradation or block of the estrogen receptor that precedes even changes in metabolism. So one of the things we want to know is if we're giving multiple drugs, how do we know we're giving the right amount? Using fluoroestradiol imaging, we can assess whether we've given enough selective estrogen receptor degrader as part of a combination of therapies. So in the patient shown pre-treatment on the left, you can see that there's a number of uptake in the bones. That osseous uptake reflects not only tumor foci, but areas where there's increased estrogen receptor expression. And with the drug that destroys the estrogen receptor, we can see that we're giving enough. You can see on treatment, we can see on the right that the foci of estrogen receptor have gone away. Now, the reason we're interested in doing that is not only to see where the tumor is, but more importantly, to know if we're giving enough of a drug. So if therapy fails, we don't know if the therapy fails because we're not giving enough of the drug, or because those cancer cells don't need that pathway and have other ways to overcome that in terms of growth signaling. So here, as we escalated the doses of a selective estrogen receptor degrader, you can see that at higher doses, more of the estrogen receptor is degraded. So if the treatment fails in an individual patient, it's not because we're not giving enough. And that's a way that molecular imaging can be used for pharmacodynamic imaging, and can be used for appropriate drug dosing. So now I'd like to change directions and talk about something that I'm quite interested in, which is looking at immunotherapy. Now, immunotherapy has really changed how we treat cancers in a lot of ways for many different types of cancers. And in fact, it's been so profoundly changed our landscape that the Nobel Prize for Medicine in 2018 was given to James Allison and Tasuku Honjo for their work for their discovery of cancer therapy by inhibition of negative immune regulation. Dr. Allison for CTLA-4 work, and Dr. Honjo for PD-1 work. Now, tumor immunology is quite complicated, but a couple of points to remember is that there are T cells that are used to sample the environment, and what happens is there's dendritic cells, and there's the T cells get regulated in part by CTLA-4, and when the T cells interact with tumor cells, they're also regulated in part by PD-1. Those are commonly referred to as checkpoint inhibitors. Now, immunotherapy has changed oncology. It works by taking the brakes off the immune system. And there's a marked improvement in outcomes. Response rates to these therapies are significantly higher than to standard chemotherapy, and those patients that respond often can have more durable responses than with standard therapy. But it's important to remember that immuno-oncology therapy fails in most patients, and response rates are often less than 50%, depending on the regimen and tumor type. And there's a reason we have brakes on the immune system, and that's because the immune system can be in overactive states, can attack normal tissues. So there's toxic side effects, especially when you combine different checkpoint inhibitors. And we can see that in patients who are given checkpoint inhibitors that adverse events can occur in a majority of patients, and these can be quite severe or even fatal, especially in more aggressive regimens. So we need different markers to assess immunotherapy response. And there's thousands of trials. If you go to clinicaltrials.gov, you can see the trials that are involved in checkpoint inhibitors and other immuno-oncology pathway therapies. Now, one of the, as I mentioned earlier, FDG is amazing, and we use it quite a lot, millions of times a year. But in immuno-oncology, immune cells use sugar and immune cells take space, and so do tumor cells. And so as the immune cells go into a tumor, we need to differentiate whether our therapy is working and that the immune cells are just taking space. That's called pseudoprogression. So you can see here, after immunotherapy started, the tumor's gotten bigger, and other focus becomes apparent before subsequently, as the immune cells are killing the tumor, that signal goes away. Versus true progression, where tumors continue to grow. And because it's hard to differentiate these, sometimes patients are kept on inappropriate or ineffective therapy for a long time because of this concept of pseudoprogression. When I think of how to assess immunotherapy response, I think of 6 large areas. One is we can do anatomic imaging. We can get a CT scan, we can get an MR scan or ultrasound and measure a tumor, whether it's getting bigger or smaller. We can do a biopsy and look at genomics of the tumor. We can try and directly image the immune cells. We can look at CD3 or CD8, potentially even reporter genes for some immune cell therapies. We can look at metabolism, and again with the confounders that I mentioned, where glucose metabolism may reflect a combination of immune cell glucose versus utilization versus tumor cell utilization. We can look at immune modulators and image those. Another thing is to look at immune cell activity. That includes things like DNA analogs or looking at granzyme B. So again, as tumor cells are being killed by T cells, as the T cells interact with tumor cells, we can look at markers on the T cell itself, whether that's CD8 or reporter genes. We can look at PD-1, which is also overexpressed in this combination of the interaction of the T cells and the tumor cells. We can also look at granzyme B, and I'll be talking more about that in a minute. Some very nice work from Elizabeth de Vries's group from the Netherlands was published some years ago, where they radio-labeled an antibody for PD-L1 and looked at the uptake and used that to assess response. What was interesting is that the expression level didn't necessarily correlate with the response, but the imaging very nicely separated out progression from non-progression. So potentially a useful agent when people are getting PD-L1, anti-PD-L1 therapy. Some very nice work several years ago from Sam Gambier at Stanford used reporter genes to look at CAR Ts. These are engineered T cells, in this case targeting brain tumors, and you can see that there was higher uptake in the imaging, which reflected the infiltration of the CAR T cells in these brain tumors in these patients. So again, there's a number of ways in terms of cellular-based therapies which are gaining increasing use around the world. We can potentially use reporter genes to follow where those T cells are going. Some very nice work out of Memorial Sloan Kettering using a CD8 imaging agent, where here you can see there's a focus of tumor, melanoma in this case, and you can see here that looking at that there's CD8 infiltration. You can also see that in hepatocellular carcinomas, again to follow where the T cells are going and when they infiltrate tumors in the setting of checkpoint inhibitor therapy. An approach that we've been interested in using is looking at active T cells, so not only looking at where the T cells go, but when they're actually actively killing tumor cells or other cells. And what granzyme B is a enzyme, is a protein inside T cells that when they interact with tumor cells, they release porphyrins, which create channels inside the tumor cells, and release granzyme B, which goes inside tumor cells and results in apoptosis. What our imaging approach does is look at the extracellular granzyme B to try and identify where those active T cells are. And we believe that granzyme B is useful not only for checkpoint inhibitor therapy, but also CAR Ts for solid tumors or even tumor vaccines, because they all have a common downstream pathway. Now, this is the last mouse picture, but I just wanted to show that you can take genetically identical mice, you can implant them with genetically identical tumors, and treat them with checkpoint inhibitors, which again take the brakes off the immune system. And some tumors respond and some tumors don't respond, and that's always impressed me. With our imaging agent, the granzyme B imaging agent, what you can see is that we're able to identify which tumors respond by increasing levels of radiotracer uptake, which again images granzyme B even before there's any changes in volume. So by doing early imaging, we can potentially see which tumors will subsequently shrink. We've taken this to patients at several different institutions around the world, and you can see here in this patient with melanoma, image at Mass General, that there's metastases at T10 and T12. You can see the granzyme B uptake. This patient was started on pembrolizumab, which is a PD-1 inhibitor. You can see that there's a lytic focus in this vertebral body in this patient with melanoma. You can see after treatment is started, again, monotherapy with PD-1, which is a checkpoint inhibitor. You can see that start to fill in as the tumor cells die. You can see the granzyme B radiotracer uptake at that site. One last example, which in another patient with melanoma, there was an FDG scan done at baseline, and you can see that the tumor is uniformly hot throughout the tumor, that there's high levels of FDG uptake representing high tumor glucose metabolism. We then performed a granzyme PET image. You can see that part of the tumor has high levels of granzyme B radiotracer uptake, and some have low levels. And what we predicted in real time was that areas with high granzyme B signal would subsequently respond, and areas with low granzyme B signal, unfortunately, would subsequently have less of a response. And a follow-up FDG PET exam showed that to be the case. So you can see that this area has lower FDG signal in areas with high granzyme B activity, and areas with low granzyme B activity, subsequently the tumor grew more rapidly at that site. So potentially a lot of interesting work on the horizon in terms of immuno-oncology as well. So some take-home points about precision imaging and how it relates to precision medicine. I think a framework of common abnormalities can help us take a reasonable approach between two extremes of group size. One is that every tumor is different, or all tumors from an organ should be treated the same, and the right answer is probably somewhere in between. And we can use these sets of expected signal changes to improve group outcomes by optimizing each individual outcome. For example, by treating only a subset of a population that's going to benefit from a specific therapy. And really, imaging is vital to this process of precision medicine, resulting in the need for precision imaging, which allows such individualized decision-making that can't be achieved by serum markers or biopsies alone. And so with that, thank you, and I look forward to answering questions.
Thank you very much for taking us into the wonderful world of immuno-oncology and checkpoint inhibitors and the things which we just read in journals, but probably in near future we'll see in Pakistan. So if we have any question, we can take one or two questions and then move on to the next short presentation by Professor Lee.
Thank you very much, Umar, that you have given a very beautiful and nice lecture, and which has certainly illuminated our minds. But one thing which I wanted to ask is that we knew already flare-up phenomena in nuclear medicine in CA prostate, and there was no need to treatment. You have given us another sort of imagination, which is called pseudo-progression. Well, I hope that it does not need any treatment. So please tell us about it.
Professor Umar, we cannot hear you. Probably you are on mute.
I don't know if you can hear me. Hello?
Yes, now we can hear you.
Okay, great. Yes, and thank you. So, you know, I love FDG. We use FDG obviously a lot every day, but because immune cells use sugar and take space, it's sometimes hard to differentiate. So, you know, with these other approaches, just like we don't use FDG too commonly for prostate cancer or for neuroendocrine tumors, I think for when we're assessing immuno-oncology and we really want to assess the T cells directly, there's a number of different approaches. And so we do see the flare response. Some of that flare response with FDG is because of the immune cells, but one of the things we'd like to do is have an earlier response assessment. So I think, like I said, I love FDG, but I hope for immuno-oncology assessment, some of these other tracers keep advancing. Thank you.
Thank you very much. There's another question, and I think this will be the last one because we have to move on to the next.
Thank you. Thank you very much, Dr. Shazia, for providing me this opportunity. Professor Mahmood, I'm Dr. Numair from Inmol Cancer Hospital, and we're doing a lot of FDG PET-CT. We have been dealing with the R-CHOP therapies in lymphoma patients, and we saw sarcoid reaction in many of those patients. With checkpoint inhibitors, the immunotherapy is still not that easily available in our centers. So some of the patients who have received immunotherapy, they have shown some pseudo-progression. What is your opinion about the, there is some different pathology working for the pseudo-progression as compared to the sarcoid reaction that we used to see with lymphoma? Thank you.
Yeah, no, and that's a great question. So I think that sometimes we can use time to help us differentiate. So if we don't have any other better approach, over time, sometimes over months, we can the immune system can be differentiated from true progression. So ideally, we'd like to not have patients on ineffective therapy for additional time, but if we don't have other choices or other ways to assess that, we have to wait and see. And I think in the next several years, we'll also have better imaging agents to differentiate sarcoid using maybe some macrophage-targeted imaging agents as well. And I think there's some interesting work trying to differentiate sarcoid from lymphoma that hopefully is on the horizon in the next few years.
Thank you very much, Professor Umar, for being with us for question-answer session and for virtually coming with us in this 8th annual meeting of PSNM. This wonderful word of precision medicine is not possible without help of radiopharmacist, and our next keynote speaker is Professor Lee. I invite our guest speaker for the next keynote talk, who has joined us from South Korea. Professor Dr. Young-Sung Lee is a distinguished full professor in Department of Nuclear Medicine at the College of Medicine, Seoul National University. Professor Lee is a prominent figure in the field of nuclear medicine and radiopharmaceutical, and has made significant contribution to the development of novel radiopharmaceuticals, including 177 lutetium, gallium-68, and F-18. He has published over 134 research papers in internationally renowned journals, with having more than 3,500 citations. Professor Lee.
Assalamu alaikum. Good afternoon, everyone. I'm Young-Sung Lee from Korea, and it is great honor to be here and share our recent progress in diagnostics in Korea. I'm a co-founder of the Click and Bio and then CTO. And in radioisotope therapy, radionuclide therapy in Korea, we started from the thyroid cancer therapy with iodine-131, just like another country. And also we set up the iodine-131 MIBG, and then earlier hepatocellular carcinoma for treatment of the radioembolization agent, such as yttrium-90, glass microsphere, or lesion cell spheres. And after that, we set up the prostate cancer treatment with the lutetium-177, and then just like for alpha therapy, we set up the actinium-225. Actually, our iodine-131 therapy started from the 1960s. So after the private ultrasound cancer screening in year of 2000, and dramatically increased that iodine 131 therapy. But in a year of 2013, we have an anti-thyroid cancer screening campaign, and after that, that iodine therapy is dramatically decreased. So I think we have to find another radioisotope therapy, such as lutetium or another radioisotope. So we focus, in year of 2000, we focus on rhenium-188 because of that is produced, that was produced in a radionuclide generator, and also somewhat cheaper than any other therapeutic radioisotope, because of we can use that one generator for at least 3 months, and sometimes we can use 6 months. So I set up the rhenium HEDP because of the Professor Jae-min Jung, who is the supervisor of me at the time. He asked me to make these kinds of pharmaceutical for therapeutic purpose. So we set up the rhenium-188 HEDP for bone pain palliation agent. So we did the clinical trials with the patient. And also rhenium lipiodol for treatment of HCC, and IAEA sponsored a multinational study. But in Korea, our strict regulation of the Korean FDA, so we cannot join that international multi-center trials. So as I mentioned, that our strict regulation in Korea, so even after getting the clinically approval of the FDA, right after the year of 2017, still we cannot use the Lutathera in Korea. So our patients who go out to the, such as Malaysia, Beacon Hospital, or Germany, Bad Berka General Hospital. So there is, patient advocates speak out to our government to fast approval track of the Lutathera in Korea. So right after that, dramatically changed the situation. So PRLT for NET in Korea. So we got the national insurance covers the grade 1 and 2 GP NET, and also off-label use of Lutathera, retreat 2 cycles after the 4 cycles, and also another origin NET, such as a pheochromocytoma or lung, we can use that Lutathera. And also we have so many kinds of different clinical trials, such as Kai Biotech, that is same chemical structure with Lutathera, lutetium-177 dotatate, and also Novartis and NETTER-2 trial, also another types of PRLT, lutetium PRLT is ongoing clinical trials. So in our hospital, we made a special treatment word for lutetium-177 therapy. So that is just outpatient treatment room. And over 30 minutes injection with the syringe pump, and also we use the amino acid for protection of kidney injury, and then patients go out go home after the injection. In the patient release criteria is we just set up all the patient right after the injection of the lutetium 177, and then one day after we can take a gamma camera or SPECT images. So, but in this year, April, US NRC give the guideline draft for Lutetium 177. They said that 22 microsievert per hour. In our case, normally that mean dose rate is around over the 20. So I think almost 30% of patient is not matched with the patient release criteria. So that will be a big problem in Korea also. Till July of this year, we have 90 patients for Lutathera therapy and also 282 cycles. And overall response after 1 month, PL is almost 20%, and stable disease is 60%, and progression was the 20%. So that is necessary for that NET patient, but not sufficient. So that's why we move to the next level of the just like actinium-225 or another just like lead or 212 therapy, alpha therapy. Here is the typical example of the some good result. So you can see the fourth treatment of the Lutathera, and then you can see entirely we cannot see any tumor region after the gallium DOTATOC imaging. But some cases we cannot get good result after the 3 cycles of Lutathera therapy, but we can see also still there are remained tumor region. And that is the NET story. We move on. We set up the prostate cancer treatment with the PRLT. So we have several company in domestic company. They invent the new PSMA agent, and first one is the FutureChem lutetium PSMA. That is the peptide with the albumin binder. The name is FC701, and they did a clinical phase 1. They finished the phase 1 and started phase 2 now. And Cellbion, that is a lutetium DGUL PSMA. That is phase 1 and 2. And Novartis PSMA, and also Telix Pharmaceutical, they are going to the clinical trials. First of all, FutureChem story, they elevate the dose of the lutetium Ludota-DIPAP. So they increased that up to 125 millicurie of the lutetium, and then one good result, the PSA level was decreased up to 20.8. And another Cellbion, that compound invented by the Professor Jae-min Jung, also I think he joined after the retirement. He joined that company named Cellbion, and they collaborate with SNUH, and then we are going to under the clinical phase 1 and 2 clinical trials in SNUH. So you can see here gallium NGUL is that pair of the lutetium DGUL. So you can see after the 4 treatment of lutetium DGUL, so totally the tumor region has gone. And also PSA level is dramatically decreased to 0.53. And that compound that can apply the adenocystic carcinoma patient. So after the one cycle of PSMA DGUL treatment, so you can see that somewhat decreased portion of the tumor site. So we have now one research reactor for production of the radionuclide. So we have a plan to install the new research reactor that is dedicated for technetium-99 molybdenum production and also lutetium-177 and actinium-225 production of, in the southern part of Korea. So that is the Kijang. So we call that is Kijang law. And also in that area, we can make a radioisotope and radiopharmaceutical complex for GMP production of the radionuclide and also radiopharmaceuticals. And also we have one Korean radioisotope center for pharmaceutical, that is the GLP for preclinical test and also GMP for clinical trials and CMO of the, we can use that facility. So in Korea, we set up all the radiopharmaceutical, even though that the strict regulation. So we promote all the domestic company to produce that radionuclide and also radiopharmaceutical for GMP grade. And also we have one good company for imaging facility to produce the imaging facilities. And now I think we have another preclinical stage of the PRLT dedicated candidates. So we worked for actinium-225 therapeutics in KRAMs, and also astatine-212 labeled peptide for NAT in also KRAMs, and PB203 and PB212 labeled peptide research is doing in our hospital, and also F18-FAP and gallium-FAP imaging for therapeutic diagnostic purpose. But sooner or later we can label with lutetium-177 in IIT stage. So this is the recent progress in theranostics in Korea. So thank you very much for your attention. And have a question? I'm so happy to answer.
Okay, thank you very much for a very illuminating talk, Professor Lee. We at Anmol Cancer Hospital in Lahore have been doing theranostics since 2017. And we have successfully delivered doses to 200 patients and around 500 doses. We are treating both PSMA for prostate, lutetium PSMA for prostate cancer, and dotatate for neuroendocrine. So I would like to know how expensive is this Lutathera that you are using in your patients? And my second question is that you've also started production of lutetium. So how successful have you been in it so far as regards the patient-grade lutetium, the specific activity, and so on?
Actually, you know that I think in US that Lutathera price is around $40,000 per one dose. But in case of Korea, we less than $3,000. I'm sorry, then $30,000 per one dose. But I think after production of lutetium-177 in Korea, I think 1/4 or 1/5 of the price will be going down. And also GMP grade or high specific activity lutetium will be available, and I think maybe 4 years later. And till there, I think still we have to import that lutetium-177 from the Germany or Russia.
Thank you, Professor Lee. It was really nice listening to you. My question is, we have recently started theranostics at our institute in Peshawar. When you don't see the tumor shrinking in a lutetium dotatate therapy, most of the time we have bigger tumors in the liver and in neuroendocrine, like in the gut. Don't you think that now we need to do for some dose escalation for increasing the dose, because we are stuck into the four doses and the 200 millicurie dogma? Like, we need to escalate the things, and is there any trial going on somewhere which concentrating on increasing the doses?
That's a very good question. Because of the Lutathera, Novartis also tried to increase the dose of the one treatment, but they tried 250, and then they got some kinds of complication. So in case of the Cellbion product, the lutetium DGUL, that MTD is very low than the very high, almost double of the Lutathera. So I think maybe that compound will get more than 400 millicurie of the per one injection. So Cellbion, they expect that after clinical phase 2, they increase that up to 400 millicurie per one injection. They are trying to set up the clinical phase 2 or like that. Okay.
So my name is Dr. Ejaz from Peenam Cancer Hospital, Faisalabad. We have a huge number of liver cancer patients in Pakistan. And however, we have not so far starting trans-arterial radioembolization. So my question from you, what's your practice of this tier in your country? And my question from our people, like in Mol and Nouri, why we have not started this treatment so far?
Actually, in the clinical trial of the rhenium-188 lipiodol study, almost 70% good result. But I don't know why that the production of rhenium-188 generator is discontinued from the Oak Ridge, and also Russia. Also, they have a plan, but I think it'll take more than 3 years. And then the situation that Russia and Ukraine war is happened, so maybe that production will be more delayed. So I think, in my opinion, I think we can make a tungsten 188 in ourselves, and then we can produce the rhenium-188 generator by ourselves, and then I think we can supply your country or any other country like that. So that cost around $15,000 per one generator. Thank you very much.
Thank you very much, Professor Lee. And I think the way forward is the production of radiopharmaceutical and radioisotopes indigenously, and for that we have PINSTEC working under the umbrella of PAC, producing all those theranostic things, and maybe in future we'll be seeing a lot of things coming from indigenous things coming from Pakistan. With that, we end our academic session, and I hand over mic to Dr. Enam. 'Inam to continue with the rest of the inaugural session.
Thank you very much, ma'am. It's indeed an honor for us to have Lieutenant General Mohsin Mohammad Qureshi, Hilal Imtiaz Military, Surgeon General DGMSIS, as chief guest for today's ceremony. He's a highly experienced professional in Army Medical Corps with over 3 decades of service. He's a graduate of King Edward's Medical College, holding a graduate degree in MSc Healthcare Management and a fellowship from Royal College of Physicians of Edinburgh, UK. He also possesses a diploma in aerospace medicine and attended various courses, including those in clinical leadership and quality improvement. General Qureshi has held command positions at hospitals, medical battalions, and field hospitals, serving in challenging areas like Siachen and Kashmir. His career highlights include being the chief instructor of the Institute of Aerospace Medicine, Karachi, and Surgeon General, Director General Medical Services since December 2022. He is a distinguished recipient of awards and commendations for his exceptional services. I invite Honorable Chief Guest, Lieutenant General Mohsin Mohammad Qureshi, Hilal Imtiaz Military, to please share his views and thoughts for the nuclear medicine community.
Thank you. Bismillah ar-Rahman ar-Rahim. Dr. Shazia Fatma, President, Pakistan Society of Nuclear Medicine, distinguished guests, esteemed colleagues, and fellow healthcare professionals, my general officers, Assalamu alaikum. I'm pleased and honored to join the 8th annual conference of the Pakistan Society of Nuclear Medicine. I extend my warmest welcome to our international and national speakers and delegates who have traveled from abroad and across Pakistan to join this forum of knowledgeable, distinguished guests like you. Your expertise and experiences are invaluable contributions to our collective learning. This year's theme, Nuclear Medicine in Pakistan, Generation Next, resonates with the promise and potential that this field holds for the future of healthcare in our great nation. I'm profoundly impressed by the commitment and dedication of the Executive Council of Pakistan Society of Nuclear Medicine in organizing this event, which brings together experts, innovators, emerging talents in the field. The inclusion of pre-conference workshops on nuclear cardiology, PET-CT hybrid imaging, and radiopharmaceutical advances further reflects a dedication to knowledge sharing and skill development. Scientific agenda depicts a proactive engagement of international and national experts by sharing their clinical experiences and discussing modern techniques to innovate new horizons in research and improving existing clinical practice with consequent enhancement of patient-centered care. The free poster and paper presentations will provide a glimpse into the cutting-edge research and discoveries that will undoubtedly shape the future of nuclear medicine. The Leadership Symposium is another brilliant concept where the highest minds converge to discuss the future vision of nuclear medicine in Pakistan. Moreover, the Forum of Nuclear Medicine Debates is another interesting forum and will provide the future directions of nuclear medicine imaging. These debates will undoubtedly challenge conventional thinking, spark creativity, and guide us towards embracing innovative solutions for our healthcare challenges. A significant highlight of this conference is the recognition of excellence and contributions of leaders of this specialty. Major General Retired Amin Waqar, Hilal Imtiaz Military, and Dr. Durre Sabih, recipient of Professional Achievement Awards, exemplifies the heights that can be reached in this field. Equally important is the Young Investigator Award, which encourages and celebrates the budding nuclear medicine researchers who are the generation next of our profession. Additionally, industry exhibitions will introduce the latest advances in cutting-edge technology to enhance the standards of healthcare. Dear colleagues, Friendly radiations have a long history and pivotal role in diagnostic and therapeutic medicine. It is difficult to envision 21st century medical practice without X-ray, alpha rays, gamma rays, and beta rays, having the ability to image and treat virtually all aspects of the body. As theranostic applications continue to advance, our challenge remains to be mindful of the radiation dose received by our patient and healthcare providers. Radiation safety will come to play an increasing role in keeping physicians and patients safe. The rapid advancement in the field of radiation science necessitates an incessant pragmatic approach towards capacity building of our hospitals by modernization of infrastructure, equipment, involvement in latest research, and ensuring skill-oriented clinical training of human resource. The resource constraint challenges can be amicably met by enhancing collaboration among the sister institutions through exchange programs. This is all part of our contribution to ensuring that radiation science and technology achieve their full potential for the benefit of humankind. It is pleasing that in the recent year, despite multitudes of limitations, many centers of excellence in the field of radiation imaging and therapeutics, equipped with state-of-the-art and latest equipment, have been established in both public and private sector with major contribution from Pakistan Atomic Energy Commission. We, together as organization leaders, having the vision, the knowledge, and the experience, may jointly pave our way into the brighter future. Ladies and gentlemen, the future of nuclear medicine in Pakistan is filled with promises, and we are resolute in our dedication to trailblazing the medical advancements. Together, we will continue to raise the bar in healthcare, contributing to the well-being of our nation beyond. Thank you for your attention and unwavering dedication. Let me express one of my thoughts with you. In Pakistan, under the economic scenario we are operating, I think we are doing great service by migrating slowly towards precision medicine, precision imaging, and all the fields which effectively reduce the waste in the therapeutics and patient care. I know this treatment is probably, as Professor Lee explained, at present it may be a bit expensive to administer, but I'm very certain that the kind of human resource we have, if we start indigenizing and if we start local production of our radiopharmaceutical requirements, I think we can do a great service to our patients who deserve better health care and better attention from us. In the end, I want to express my deepest gratitude to the Pakistan Society of Nuclear Medicine for inviting me to be a part of this remarkable event. I look forward for the rich discussions, innovative solutions, and transformative energy that will emanate from this conference. Best of luck and thank you all. Godspeed. Pakistan Zindabad.
Thank you very much, sir. I would request Honorable Chief Guest to please present this souvenir to Professor Yun Seng Lee. I would request Dr. Shazia Fatma, President Pakistan Society of Nuclear Medicine, to please present a souvenir to Honorable Chief Guest on behalf of entire nuclear medicine community. With this, we come to the end of today's inaugural session. On behalf of President and Executive Council, Pakistan Society of Nuclear Medicine, I am once again grateful to the honorable chief guest, distinguished guests who have joined us from across the country and abroad, and as well as the industry partners who have joined us to support the event. I would further request all the speakers and faculty members, organizers, and members of the society to join the chief guest and President PSNL for a group photograph.
Well, the function is over, so I can have a lighter note talk. Dr. Ahmed Qureshi, I know him for the last 40 years. He was immediate junior to me in college and an avid photographer. Just a disclaimer, I'm Mohsin Qureshi, he's Ahmed Qureshi, we are not related. I'm much superior in intellectual and race.
I request all the faculty members, speakers, and society members to please join the chief guest.